This is my pleasure now to invite Dr. Fernandez Quesada, who is an angiologist and the vascular surgeon from Granada, Spain. He's also the vice president of the Spanish chapter of phlebology.
Thank you. Thank you, Mr. Chairman. In those conferences, we have a multidisciplinary participation. There is a lot of profession and a lot of professionals that can take care of ulcers. But maybe that our table is uni-professional and all of us are only vascular surgeons. Maybe for this reason, we have not so much question. And sometimes we try to understand things in opposite to the rest of the professionals. We are going to try to join different ways of understand things. When they said me and when they invite me to talk about compression or surgical treatment, I was scared. And I asked, can I change and put and? I think that it's not only to treat in a way or in another way. A lot of time, the treatment can be customized to the professional and customize it to the patient and customize it to the disease. Several patients only need one treatment and the other patient need an strategy. And this is the idea I am going to try to say you how we do things in this way. Treatment of ulcer is really, really variable. Depends of the center, depends of the patient, depends on the therapist. We can use guidelines, and each time we have more guidelines, but at least those guidelines are only a road or a map of roads to try to take care and try to fight and win to the disease. An ulcer disease is a very hard disease to find. I think that I mustn't explain you because all of us are here because we do love this disease and we take care of this disease. At least we can find a lot of experience, but so few evidence in several places of medicine. An ulcer has had a lack of evidence for a lot of years, but not now. We can have different approach to this treatment. Compression, exercise, and surgery, and more aggressive approachment with open surgery, ablative endoluminal techniques like radiofrequency or laser, and we are surgeons and we are more looking for this kind of treatment. Ultrasound-guided foam, and in last years we can try to open closed veins with deep venous surgeries and bypassing, or with stenting and recanalization. There is nowadays evidence, we can say that is now evidence to support most of the treatment. If you look in treat database or in an evidence-based tool, you can find hundreds of good level of evidence. And you can find guidelines. It depends on your country or depends of your profession. You can find guidelines, multidisciplinary approach or unidisciplinary approach. Here you have several ones. And in our country, this is American, it's in Spain, and Dr. Marilelo said before, we have the CONEOI in association with the CEFIL, was the Spanish chapter of vascular phlebologists, and the Spanish Society of Vascular Surgery. We make a consensus about ulcer in the legs, different ulcer. And I was invited to be a presenter and to be a writer of this consensus. And for me, was my first approach, like writer, to a consensus, because it was several years ago. we said in this consensus that compression has a very good level of evidence to be used. We said, too, that sclerotherapy can be supported, and any kind of surgery in venous reflux can also be supported. And then, how can we fix our algorithm? It's going to be never the same to other center and never the same to other therapists. We must know what is the more powerful treatment we have in our medium and try to use this and customize to our patient and to our possibilities. It's not the same to work in the national health system or to work in private practice or to work in India or to work in United States. And then we can try to do the best in our medium. What are the goals? What are the objectives of our treatment? First, ulcer cicatrization. I think it is the most important. Pain control, infection control, edema control, exudate control, and as soon as possible, return to normal activities, because to have a chronic disease is bad, and to have a chronic ulcer is more than bad, it's worse. We must try to control the causal process if possible and prevent recurrence, and it's one of our more strongest enemies. What can we do with the patient? It's difficult. If you say to the patient, don't smoke, do exercise, lose 20 kilos, and have a nice diet, the second advice is going to say, to look at you and say, this doctor is absolutely silly. How can I'm going to change everything in 2 days? But we must have a psychosocial support and a familiar support to get these changes slowly. We must prepare the leg, and we must prepare the wound and the skin around the wound. This is a binomius, it's not isolated thing. We must put it together. We must cleanse, and I think that it's not a good idea to talk to you about this, because you are expertise in everything of this more than us, the surgeons. What we use usually depends. The first treatment, we try to make a triple cure with different things inside the ulcer and outside. But it depends of your experience and depends of what you do in your medium. Here we can use sometimes help with pads to try to not to suffer with the compression in the place of the ulcer. Pain is very important to be controlled. The pain increases the size of the ulcer and increases the bad feeling of the patient. We can use analgesia, but sometimes, and it's very good, we can use local blockage with local anesthesia of the saphenous nerve, of the nerve that is producing this pain. And we have a spectacular increase in the healing of the ulcer just in the moment we can cut the pain. What about compression? We can use it different ways, elastic or inelastic, and each year we are more proclive to inelastic bandage. We can use done by ourselves, handmade, or commercial. And we must take care of compression, and they have told us before, in patients with ischemia. About inelastic bandage we, the vascular surgeon, are very, very scared about to lose the muscle diastole, because the muscle in diastole is when take the blood to return to the heart. We don't talk about the valves, we don't talk about the vein, and we don't talk about the muscle. We say that they are an unity, veno-musculo-valvular, that can come back the blood to the heart. there is evidence that compression can heal ulcer and can prevent recurrence. But alone, the number of, with hosiery alone, the number of recurrence is still high. Here you have an example of how we dress the ulcer, how we cover, and how we use an inelastic bandage. Nowadays, you can have a kind of inelastic bandage that can be fixed by the therapist and can be refit by the patient, and can be useful in several patients that are very far from your hospital. In our private practice, sometimes we have patients from Sevilla or from Cádiz that are 300 kilometers out, far from our city. Because Granada for several years has been very famous in vascular surgery in our country. When we must send to a surgeon the ulcer, this is the thing that says most of consensus. Prior in the table, they have said us that maybe always or nearly always. But when we have no release of the ulcer and no healing, or maybe that in 3 months we don't get, it's not worse, but it's not better, we must try to think in a change of strategy. What can we do? Well, first thing we must do is to have a clinical and an echographic assessment with more image tests if necessary, but usually are not necessary, and to try to combine with treatment of the venous disease, not only of the skin scare. What we do, they have told you, we try to make a cartography and a plan of what is happening in the veins. And the hemodynamic assessment can be made only with the echographic. Usually we don't need more. But we can get a very nice approach between clinical, the map, the cartography of the venous disease. You can see here like points, red points, like perforant disease. And with the CT, we don't usually make the CT, but we made several CTs to compare our findings in anatomy with the findings of echography. Phlebography only if we are going to treat the patient in the moment we are treating the patient. Here you can have a cartography. And what we found? We have found that pure deep venous disease is less common than we suspect before. There is a lot of ulcers that can achieve better results in healing with surgery, more than we thought before that can be used surgery. It has made us more proactive to find surgical solutions in ulcers. You can see here how we can have a reconstruction, but it's not a very, it's not a common technique because the echography usually is enough. And we have all the possibilities of treatment. Depending on what we found, we can try to customize the treatment to the patient. It's not the same to have an only internal saphenous vein reflux that can be treated only with an hemodynamic surgery, or to have an iliac thrombosis or an iliac that need an iliac recanalization and stenting. A very good tool is sclerotherapy. It's cheap, easy to perform, don't need operating room, can be made in in a consult basis, and it's a very, very good tool, and can be associated with any other kind of treatment. The idea nowadays is that we have a strategy of combining different treatment to achieve the best results. Sclerotherapy can be repeated in time in case of recurrences. Here you have how we perform echography and echo-direct ultrasound, ultrasound-guided echography. The foam is very visible inside with the echography inside the vein. And we can help with compressing the vein and cutting and excluding those veins empty not to have thrombosis, to have a chemical phlebitis. Here you can see how it's a very big lesser saphenous vein, and how in one session, only one session, we can interrupt the reflux, and the vein is going to disappear. Here you have more examples, and more. And can be used in 90 or 95 years old patient. Most of the surgery is not possible to use in very old patients. And as you can see, heals the ulcer. Or in morbidity, obesity is a very good tool to use. Here you can see how it's healing the ulcer. What more can we use? We can use conservative venous surgery, ablative. When we made this difference is to try not to be rude with veins, only to reconduct, to make a new hemodynamic without remove the veins or without destroy absolutely the veins. And ablative treatment like laser, radiofrequency, steam, or glue. SEPs, we don't use nowadays SEPs. We are not in love with this technique. We prefer to use another. And valvuloplasty and bypass in the deep venous reconstruction is now being replaced by endovascular approach. It's less aggressive and with good results. Here you have patient with an obstruction of the left iliac vein, and we have recovered. All those collaterals means that the blood is going from left to right in non-normal circuit. And when you saw them disappear in the phlebology, means that you have reopened the normal way. One more example. And the use of endovascular echography can help you to know what are you doing, most if you have you are stenting. How can we prevent recurrence? Compression, surgery, and sometimes to use soft treatment like sclerotherapy in the follow-up of the patient. And for the ending, here you are an example. This patient was treated in our hospital, in the National Health Service in Granada, el Hospital Clínico, and I want to say that we are we have the pleasure to have working with us to Paco de Aro. A lot of you can met him because he's at least very famous in Andalusia. And this patient was the mother of one of our directors. And she was taking care of this ulcer for 3 years, I think, without good results. And Paco said us, can we try to do something to cut the recurrence? And we make an echography and find that the patient has a saphenous and perforated disease, a saphenous of more than 1 centimeter and 50, and was very, very rude. And we make an local surgery with local anesthesia, and you can see that the healing in 1 month get better, but was not able to close. And then we found that there was a perforant and perform an sclerotherapy complementary to the surgery, and here you have the results 2 months after the sclerotherapy. So, what can we do? Nowadays, we make more conservative treatment. Indeed, aggressive treatment are more conservative than 20, 40, or 50 years ago. we must adequately staff materials and the environment to the patient we are treating and to the disease we are treating. And if the results are not the result you are expecting, you can consider at least the aggressive approach. At least, depending on the type of patient, the type of disease, who is treating the patient, I think that the best results are with a multidisciplinary approach. And the preference of the therapist and the preference of the patient, we can try to choose, to customize the treatment to our patient and his disease. With the best cost-benefit ratio, I'm trying to have the less interference with the patient activity. Thank you very much.
Thank you very much. We have a time for one question, please. Thank you very much for reviewing for us all these techniques. If there is no question, please allow me on behalf of all the speakers here to thank you very much for coming for this very interesting session, and I will sum up the session in 4 points. So that will be a sort of messages you should take home. And I think the first one is that the venous leg ulcer is really a very prevalent disease, and it doesn't matter what you do, from time to time you will see the patient with the venous leg ulcer, and you should know how to treat it. The second thing is that you should look locally and systematically on the ulcer. So ulceration and hemodynamic examination should be the very important moment to really not only diagnose, but also treat the patients. Then look always whether the arterial side is not involved in the venous leg ulcer. And all this method which was presented here, especially the ABPI index, should be measured on every patient. And last thing is that I think we should always size the treatment to our patients, which should be based on our knowledge, probably guidelines, but also the patient's preference. And with that, I will leave you here. I will wish you a very nice evening in Madrid. And once again, thank you very much for coming here. And I thank you all the speakers taking part in this session. Thank you very much.